everyone, welcome back to my IVF Answers. Welcome back to the European Fertility Society and our webinar tonight. I'm very happy to be back once again. And as you can see, our special guest is right here with us. Dr. Oliver Pack is right here, and
Good
he's
evening.
talking from Alicante. So, good evening. Welcome to my IVF Answers English version, actually, because you already had some webinars in Spanish, right? So, I'm glad that this time you will speak to our UK patients mostly, but of course there are other patients from different countries. So I'm glad that we are here tonight, and we will talk about fertility in 2023. And of course, Dr. Oliver Pack has prepared a presentation on the latest advances in at IVF Life Alicante, where he is the fertility specialist. Dr. Pack, great to have you. How are you feeling tonight?
Yeah, thank you very much for your presentation. Good evening to everybody. So I've just finished I just said goodbye to my last patient. So quite busy. As we mentioned before, we have a lot of work here. But I'm still fine. I'm still ready to give this presentation. I feel that I can tell you and transmit you many interesting questions we are going to discuss. So yeah, I'm
Great.
ready. As soon as you wish, we can start.
Glad to hear this, of course. And just remember that we will start with the presentation, but afterwards there will be time for your questions. So all you need to do is just put those in the chat section so that Dr. Oliver can help you out with those. Remember, you can ask him anything. So this is all anonymous for everyone. So feel free to do so and get some advice. And let me just also add that as we are still looking for volunteers, so if you would like to support us, you can go to my IVFAnswers.com website and help us out. And if you want to find out more about what kind of volunteers we're looking for, please just get in touch with me. I'm your host, Caroline. You will find my email address in the chat as well. So this is just something I would like to add. Thanks everyone for joining us already, and let's get going with our topic tonight. It's going to be interesting for sure, and I think it's time to start. Dr. Oliver, ready to begin it?
Yes, I'm ready. Okay, I will
Brilliant.
just
Let's do
briefly
it.
present myself. My name is Oliver Peck. I'm German. You hear it from my accent, but living in Spain since many years. I've also studied here. So I was first a GP, but then I decided to specialize in this very nice field, reproductive medicine, and I'm working here in IVF Spain. Well, now it's called IVF Life for 5 years now. So yeah, so let's get started because there are a lot of things a lot of different topics. Okay, it's about latest advances in reproductive medicine, but we will obviously also mention, generally speaking, the techniques we are applying in our treatments, and some treatments that are still investigating. There's still ongoing investigation. It's still experimental. And there are other treatments which we also have huge experience and also evidence that it can really help to achieve better pregnancy rates and live birth rates. So yeah, let's get started. So first, just a brief picture about reproductive medicine and fertility treatments in Spain. So these data are from 2020. Spain is the third country where most fertility treatments are performed. I think India and Turkey are on place number 1 and 2. Spain comes on number 3. So this is something that was made, let's say that one of the big reasons why Spain is relatively advanced is because of this huge volume of people who come here for treatment. And this is one of the main reasons is because of egg donation. Okay, this is a very popular country to do egg donation treatments, and people come from all over the world to treat themselves, to receive donated eggs, and it's highly successful. So this is probably the main reason why Spain has become so advanced, because of this big volume of patients that come every year. So how important is ART, which is artificial reproductive technologies? Okay, so we are speaking basically, when we say ART, we basically mean IVF. That's what we do all the time. Okay, so nowadays around 9% of births are achieved thanks to artificial reproductive technologies. So what is the reason? Why do people need IVF? Basically, because there are two reasons. It can be male, it can be female factor, or it can be both. Okay, the most mostly male factor is relatively easy to resolve thanks to ICSI. ICSI means intracytoplasmatic sperm injection. With this is not a latest advance. It is there. It's around there since many years, and it's highly efficient to resolve sperm problems, especially low concentration, low motility, bad morphology. All this can be in major part of the times it can be resolved thanks to the ICSI technique, which means catch one sperm with a syringe and inject it into the egg. Okay. Female factor is more difficult to resolve. It strongly depends upon the cause. And normally, it's not only one cause, because it doesn't work. There are so many different factors that can interfere in the process of fertilization, implantation, and the growth of the baby especially during the first trimester, that it's very difficult to put it down to one cause. And especially when implantation fails, then it's very difficult to know. There's so many different factors. Some of them are not yet even investigated. But the reason why why couples need IVF normally is due to age, of female age, not male age, female age, because female age is still a big challenge. We'll come to that. So 30% of cases, there's not only one cause, there are two or more causes. 30% of the infertilities are mixed, have a mixed origin, male and female. So yeah, 40% of the treatments are due to advanced maternal age. Okay, this is the thing. Women generate their eggs when there were embryos. And these eggs basically have the same age as a woman. And this is a major issue for the egg quality and quantity. Quantity because eggs are spent. There is an egg reserve that cannot be renewed. There's no way how we can regenerate eggs, not yet. Perhaps in 100 years it's possible. But right now, there's no way how we can regenerate eggs. So the eggs are spent every month. Every month, a woman spends like 20, 30, 40 eggs, and only one of them will grow. This is a dominant follicle. And this is the only egg that gets expelled and perhaps fertilized and so on. So this is the problem, that the eggs what is advanced age? Advanced age is women, I would say, over 38. This is an age where it starts to become difficult. And over 40, it's really difficult. And over 45, it's basically impossible. So you can see that in little years, which is from the age of 37, where it's still good, till the age of 45, that's only 7 years. Sorry, 8 years. 37 to 45, yeah, 8 years. In only 8 years, it starts being very likely to succeed at the age of 37, and it gets impossible only 8 years later. So, so when I speak of advanced age in women, I always refer to the age of the eggs, okay, not to the age of the woman, because the women are splendid at that age. So yeah, 40% of the treatments are due to that cause, maternal age, low egg reserve, which always comes together with low egg quality. And 1/3 of the egg donation, of the treatments, are egg donation. 1/3 of the babies born thanks to IVF is thanks to egg donation, which is yeah, it is very, very successful. We will come to that. So what are we facing? We are facing, the main problem is maternal age. New family models, new advances in reproductive medicine. So let's start. And what means advanced maternal age? Spain is the second country where motherhood is delayed the longest. Okay, in this case, I don't know which country is number one, but it's totally clear, and there are many different factors that are causing this fact that women start to go for the first kids each time later in life. Okay, so one of 10 women have their first kid at the age of 40. So what are the reasons? Job insecurity, housing prices, I cannot afford to have a baby. How do I make work and my lifestyle, my life, and having a baby, how does it work together? Okay, how can I find a balance there? That's very difficult. COVID has also meant a huge delay for many people who wanted to treat themselves, and during 1 or 2 years, many people delayed their plans due to COVID. So all these factors contribute. What are the solutions? Okay, for old eggs, there's no, solution. It's very difficult to talk about solutions. The only real solution is egg donation. Egg donation is definitely how women over 40 and even up to the age of 50 can have kids. Okay, because it depends 90 something percent of the maternal age of the eggs. This is a big problem, and this is 100% resolved by egg donation. Now, what if, okay, let's say she's 38 and you will not tell her that it's not possible, obviously. There are chances, there are even good chances. So from the age of 38 onwards, what we face is that the embryos, that it's still possible to get embryos, blastocysts, but the problem is that many of these blastocysts will not be healthy blastocysts, chromosomically speaking. We are not speaking about healthy babies. Okay, many people think that pre-implantation genetic testing will tell us anything about the health of the future kid. We've not yet reached that point. We've reached a point where we have to see whether an embryo is able to give a kid or not. And this is what pre-implantation genetic testing can tell us. So we will be able to detect embryos where there's a missing chromosome or a supernumerous chromosome. And then it strongly depends upon which pair of chromosomes is affected to see whether there can be a baby or not, because you probably have heard of trisomy 21, trisomy 18, and trisomy 13. When these three pairs of chromosomes are affected, even a baby can be born. And then this baby will not be healthy. Okay, this is only for these three pairs, and also Turner syndrome. Such sexual chromosomes can also be affected. But this is where chromosomes really affects the health of the kid. Because what happens if chromosome pair number 1 or 2 or 3 is affected? Nothing. There won't be any baby. Okay, it's simply not capable to give you a baby, that embryo. So you can detect these embryos and discard them. This is PGTA. And obviously, when we know that the embryo is euploid, we also know that it doesn't have a Down syndrome. Down syndrome risk in a 38-year-old is 1 of 80, more or less, or 1 of 100. It's a considerable risk. So this is why PGTA is also interesting to rule that possibility out. One of the so-called viable aneuploidies. So yeah, but what if we are not able to get blastocysts anymore? This is frequently the case. Basically, our couples who come for egg donation to Spain, we calculated that once. Statistically, the number of IVF cycles, of failed IVF cycles that our patients have performed before they come here for egg donation is 5. So why is it failing? Always the same story. I wasn't able to get embryos. I wasn't even able to, they canceled my puncture because the follicles were not growing. You know, many things, there are many ifs. First if, will my follicles respond? Second if, will my follicles contain a good egg? Will it be mature? Third if, will this egg get fertilized? And then there are many ifs. Every day, it's the question whether the embryo will continue developing. We usually try to get our embryos, makes them reach day 5 of development, which is the so-called blastocyst stage. Okay, blastocyst stage is an embryo. If the embryo was able to reach day 5, it's still no proof that it's a good embryo, but let's say that the chances that it's a good embryo are much higher than on day 3. So day 5 culture, this was a very important advance in fertility, that we were actually able to let the embryos, make them reach day 5, because formerly it wasn't possible. The embryos that just didn't survive so long. But now the culture liquids are much better, so they can reach day 5. And it's not that an embryo will be better in the womb than in the culture liquid. Basically, an embryo has the same chances to survive till day 5 in the liquid, in the culture, than in the womb. So yeah, this is one thing. And then you can, even if the blastocyst, even if we achieve a blastocyst, then still there is a big question whether it does or not carry 46 chromosomes. This is where PGTA comes into play. Okay, and in a 38-year-old, more or less half of the embryos will not be healthy. But if the woman is 42, let's say, then it's only 1/3 will be healthy. And if she's 45, only 1 of 10 embryos will be healthy. And this is what many women just can't believe, that her embryos, even if we get a blastocyst, chances that this one is a good one are very low. And still we don't have a baby. Still we have, let's say we have the big luck and the embryo was actually euploid, and we transfer it, still chances to succeed are relatively high then when the embryo was euploid, but still it's not more than 50%, well, a little bit more, probably 60% or so of live birth. Okay, live birth rate around 60% when the embryo is euploid, which is not bad. But the problem is that in women older than 42, it's really difficult to find a euploid embryo. And if we have one, we might have only one. And what we do, we collect embryos. I will also explain something more about that. Okay, so for all these problems, when we do cycles with own eggs, egg donation is the solution. We have many donors. I told you before, Spain is one of the meccas for egg donation. And yeah, a young lady will give us many eggs and high quality eggs. So we will get a lot of blastocysts, high quality blastocysts with very high implantation and live birth rates. More or less 45%, 45-50% is the chance to have a kid with only one blastocyst from a donor. And then it's very easy, if one blastocyst fails, it's very easy to have another one. So this is why it's so successful. But we also have couples who just don't accept egg donation. This is a very personal thing, sometimes even for religious reasons. When egg donation is not an option, there is one experimental treatment. I'm saying experimental because there's still no evidence that it can really help. I'm speaking about ovarian rejuvenation. Ovarian rejuvenation consists in infiltrating, injecting basically PRPs, which is this is called platelet-rich plasma, into the ovaries to stimulate and to be able to achieve, possibly, not always, but possibly to achieve more eggs than we would achieve in a normal cycle. So we might have a slightly higher amount of eggs that can be stimulated. Okay, because we can stimulate only the eggs that the body gets prepared for growth. Okay, we are speaking about ovarian rejuvenation. It's very solicited, this treatment. The thing is that it's still, we don't have good tools to select women where it might work, where it might really help. This is a problem, because in many women it doesn't work. It doesn't give us higher number of eggs. You know, we possibly in 1/3 of cases, and it strongly depends upon the egg reserve and the egg quality and the age. So we are still not able, even with ovarian rejuvenation, this is not a solution like egg donation. You know, nothing, you cannot compare it. Egg donation is just 100% solution for the problem. Ovarian rejuvenation might be a little help, might be, and it's still not proven whether it's really helping. There are a lot of clinical trials, ongoing clinical trials, and it still has to be proven that it can really help. Fertility preservation, we are speaking about freezing eggs. This is something I strongly recommend to all women. There's an age where it's highly convenient to do this before a woman gets 37. 37 is when egg reserve starts to decline quickly. It starts at the age of 35, but 35 is still a good age to freeze eggs, and it shouldn't happen later than 37, because then we face the same problems, that the eggs, we have lower amount of eggs and less quality. And we also have to keep in mind that when we freeze and thaw eggs, we will lose 30% of those. So in order to have a good number of eggs, to have really good chances to have a kid later in life, you should have at least 15 eggs frozen. 15. You should be under 37, and you should have around 15 eggs frozen. This is a good number. Okay. I've already some incoming questions. There are many things to explain. I don't know whether it's possible for me to read and to enter in particular cases, because I see that patients are describing me their particular case, which is, you know, this is something that is very difficult to analyze in these webinars. I think I can only answer short questions. Let me see. What do you mean by the fact that egg donation will solve the problem in 100%? I'm saying that the problem of a bad egg reserve, of a low egg reserve, and low egg quality is resolved. This problem is resolved with egg donation, because we get eggs from young, healthy ladies, and they have to be under 35. So a woman, regardless her egg reserve, regardless her age, you know, it doesn't matter whether she is 30 or 40 or 45. It doesn't matter. She can be even 50. With egg donation, she will have the same chances as when she was 20. This is what I meant when I said that egg donation is a solution for age-related bad egg quality and egg reserve. So what are we facing in 2023? New family models. We have a lot of single women. This is just times are running, and a lot of women decide to be mothers alone, to do it alone. So, and we also have a lot of same-sex couples. And there are specific options, specific treatments which are particularly suitable for these kinds of patients. For example, a single lady, the best treatment we can offer for a single lady is embryo donation. Okay, she doesn't need, she's going, well, normally she can also do IVF, obviously, if she's young. But many times, the big majority of single ladies that come to us have a certain age, over 40 normally, and then the only solution is egg donation. But in this case, as she also needs sperm, there's no difference between generating an embryo with donated eggs and donated sperm, and transferring an embryo that was donated, that is already generated. Okay, the chances, the success rates are identical. So I'm reading more questions. What is your opinion? The use of, let me me see, of growth hormone. Well, growth hormone is actually one of the very few treatments that it's not yet 100% proven, but it's likely that it can help to improve egg donation. The big problem of growth hormone is that the use is off-label. There's no official indication to use it in IVF, and this is why in many countries it's not available. We in our clinic, we have a pharmacy where people can buy it, but in other countries it's nearly impossible to get. I will enter in all the questions. I think we should just continue with the presentation, otherwise it will be a bit messy. So yeah, a single lady, the perfect treatment is embryo donation or egg donation, or if she's young, we can still do IVF with donor sperm, obviously. And in same-sex couples, these couples usually opt for the ROPA method. So one normally the younger of the two opts to stimulate herself to get her eggs retrieved, same as if she were a donor. She's donating the eggs. The eggs will then be fertilized with a donor sperm, and the other lady of the couple is going to be the receptor of the embryo and carry out the pregnancy. Okay, this is also a very common treatment we do here. Let's go ahead. New advances in reproductive medicine, customized stimulation protocols. Okay, it's very important to analyze very thoroughly. Every patient might need a different stimulation protocol. Okay, this is there are new protocols. Basically, we are using in our clinic we are using the antagonist protocol. But then, which dose you are using, how and when to start a stimulation. This is something that has to be very individualized decisions. There is no general protocol for everybody. We have technological advances. We have advanced diagnostic tests. Artificial intelligence is also entering in the game. I'll explain you all that. So customized adaptive ovarian stimulation protocols, it strongly depends upon follicle count, AMH level, and these two parameters strongly depend also upon age. And then we will have a very specific forecast. We can make a forecast about what and how the stimulation will go, whether she will be a good responder or a poor responder, and how many eggs we can expect. You know, it's very important to know more or less what we can expect. Again, strongly age dependent. Duostim, we perform and we make a stimulation, egg retrieval, and just after the egg retrieval, only a few days later, we restart another stimulation during the luteal phase. New follicles have been formed. You might not see them because you've just done a puncture, so you cannot see those, and new antral follicles that are there, but they are there. So if you start a stimulation directly after a puncture, it also gives good results. Okay, you do not necessarily need to wait a month between one stimulation and another one. We do duostim a lot in couples who come from far away. You know, we have patients from Australia, from the United States. So when they come to Europe, they usually want to take advantage of the fact that we can do 2 stimulations in, let's say, a 3-week stay is sufficient to do 2 stimulations. So 2 stimulations, double number of eggs, double number of chances. Androgens, PRP, I was mentioning that before. These treatments might help in certain conditions. PRP, as I said before, it's still experimental. It is also very important to select patients here, because when we have a low egg reserve and age, and if all bad factors and predictors come together, then PRP will not, it's very unlikely to be helpful. Okay, strongly depends. So time-lapse technology, that was also a big advance. We use that it's like common use in our clinic. We make a time lapse so the embryo is filmed, and you can perfectly analyze all the different stages of the division of the embryo. You can see first on day 1 it's 1 cell, on day 2 it's 4 cells, on day 3 it's 8 cells, day 4 50 cells, and on day 5 it's a blastocyst, more than 200 cells. The whole process can be filmed, and the embryologist is able to extract additional information about the quality of the embryo by watching these videos. And there's also a software analyzing specific patterns of development, which helps with the grading of the embryo. Okay, techniques to treat the male factor. This is also a very big issue. Okay, we have when we do cycles, especially also egg donation, sperm of the husband is usually participates because men usually are still able to produce sperm. Let's say that the sperm quality in men is normal till the age of 45, even 50. So, but we do have a lot of cases where the sperm quality is affected, and then there are different methods that can be used to select good sperm and to separate it from the bad sperm. Okay, this on the picture here you can see some magnetic. It's called magnetic cell sorting. The bad and the dying and bad quality sperm cells will connect to a magnetic substance and can be separated from the good moving sperms that will not connect to this substance. This is called MACS, M-A-C-S. There are many different methods, CIMER, PIXI, advanced seminogram, where we look at fragmentation rates, apoptosis. You know, it is very also highly individual which of these methods could be indicated in each patient. So endometrial receptivity test, this is a genetic test of the cells of the lining that can tell us the degree of receptivity. This is very interesting. We do biopsies, endometrial biopsies all the time, especially when the first transplant has failed. The test will tell us whether in the very moment where we normally would transfer an embryo, which is 5 days after the start of progesterone, okay, this is when the lining is supposed to be highly receptive for the embryo, but not always, because as everything in nature is, it varies, it can vary. The window of implantation can reach let's say the receptivity can reach the maximum point. It's like a curve that increases, reaches a maximum, and then it decreases again. And we want to transfer the embryo, obviously, when it's in the highest part of that curve. So this test can tell us whether there is any, whether the window of implantation is displaced. Let's say it can be shifted. It can be sooner or a bit later. So if a woman is pre or post receptive, then we can adapt the time of progesterone in the real cycle. So this is one of the most important tests we do to improve our, to resolve some issues of women who are transferring embryo and it's failing. You know, you're not going to transfer 2 or 3. You don't have so many. So normally after the first failed transfer, you consider doing this test. We do immunological testing, natural killer cells, T helper lymphocytes, many different cell types that are implied in the immune response towards the embryo. There is a thing called KIR-HLA-C genotyping. That's a bit difficult to explain, but let's say that KIR are the receptors on the surface of the natural killer cells of the woman in the lining. This is a receptor, and it has to connect with the antigen on the surface of the embryo. And there are specific combinations of KIR and HLA that do not carry well together, where we have seen that there could be, this is something that is not yet proven, but it could diminish the chances for a pregnancy when one of these combinations is given. Immunological tests. We also use artificial intelligence. This is, well, it's not us. We have not developed this system, but AI is being used in many different things. And this is AI is also into the program looks at the development and at the structure of the embryo. So it is basically it's a picture of the embryo is analyzed by a AI, and it's not bad. We still rely more on our embryologists, but I think it's also it might be helpful in the future, and probably it will become better because its intelligence is going to improve probably. So these kind of programs might also be able to help us with the selection of good embryos. And also sperm selection could be done by AI, but we are not using it. Right now we are only using AI for, it's a help, let's say an additional help for the selection of good embryos to our biologists. But we still rely more on time lapse and on our criteria to assess the embryos. Okay, this was a lot of information. We have touched a lot of different topics. So this is basically all the technology that we're using here in our clinic. Let's have a look at the questions that I have written here. So
brilliant. Thank you so much indeed for your presentation. I'm right here,
You're
of course, and now it's time for your questions. So as you see, there are plenty of questions ready. So let's get going with those. Okay. I know that you've mentioned the longest one. We will simply forward to the team at IVF
Yeah.
Life Alicante. Okay. So that we
Yeah.
can, so the team can, of course, help with those. And let me just go to the next one. You've answered some of those questions, so let me just go to the next one. You've mentioned you also, I don't think this was answered. If you can perhaps have a look, what is the upper age limit for fertility rejuvenation?
Yeah, there is no age yet where we tell, okay, it cannot help. The thing is, first we have to see, the problem is that we still are not able to really make a good selection of women where it can help because it fails many times. Okay, and when it's failing, we still shrug our shoulders. We don't know exactly why. We know that only perhaps in 30% of cases we are able to achieve a slightly higher number of eggs. Let's say we have a woman, typical example, she's 45, but she still has some egg reserve. She might give us 4 follicles which can be stimulated and become eggs. This is the potential number of eggs that we can get. So when we do an infiltration rejuvenation of PRPs, then you have to wait 2 months, and 2 months later we might do a stimulation, and we might find, instead of 4, we might find 6 or 7 follicles. Okay, 6 or 7 follicles instead of 4. But the number of cases where this really helps or really works is still relatively low. I told you, more or less 1/3 of patients. We might get a little. Until what extent these eggs have improved their quality? This is also very difficult to measure, because the quality is very bad by itself. It's sometimes I say, if you in some women it might be the solution, but we cannot prove it. It's very difficult to know whether it was you just won the lottery or whether it was thanks to regeneration. So having more eggs still doesn't mean that you will have embryos, and it might not mean that you have more embryos or higher quality embryos. I think there is still a lot of investigation to be done in this field.
Of course. That makes sense. Of course, as you can imagine, lots of questions in regards to fertility rejuvenation. So perhaps if you can have a look at this question, in what cases have you seen PRP treatment be successful? Anything you can say about AMH or AFC-H?
In what cases? Okay, I think I mentioned before that when the woman is over 45, it is so difficult. You know, these women might have a less than 1% chance. Let's say a 45-year-old woman might have 0.5% chance to succeed without PRP. And perhaps with PRP, she might double or triple her chances, but it's still a very low chance to succeed. So it's very, you know, we've had cases where we have seen more eggs, but we've not seen like miracles. Like, well, there might have been a case of a 50-year-old. She was menopausal and she she got eggs. Suddenly, she got eggs where she was supposed to not have eggs anymore. This case has been described in the literature, but still, that woman didn't have a baby. You know, if you have the eggs, you're still very far from having a baby. This is the thing. There are many ifs, and it strongly depends upon egg quality. And it's not clear till what extent PRP is really improving the egg quality. So it remains to see. When in our clinic, we're also going to do a clinical trial very soon. And then we can say, you know, base your opinion upon experience is not very reliable. So yeah, we have to do more investigation.
Still, more to be able to give you like a proper answer right now is still
AMH level. We've had cases where AMH level got increased. It's but AMH can also vary without doing PRP. So it's not always clear whether the increase was thanks to PRP. It's very difficult to say. If it helps, it's not the, you know, if it were really helpful, we would do PRP to everybody, even before the first stimulation.
Right.
This is not yet the case. We are not there. We have to study it.
Yeah, we need to wait still, of course. That makes sense. Okay, let's have a look. Fran has some details, but if you can have a look. Latest IVF at age 36, 21 eggs, 10 blastocysts.
10 blastocysts, amazing.
10 fertilized.
10
3 euploids.
A bit low.
Is this a satisfactory result?
Yes.
And
yes,
how might this increase the potential?
3 euploids is not a guarantee to have a baby, but chances are really good with 3 euploids. I would say that one of the 3 attempts that this lady has is successful is around 80%, I would say. Yeah, this is amazing. 36 is also a very good age. Egg quality is still conserved. She has also, if she got 21 eggs, and a very high blastocyst rate, you know, 10 blastocysts from 22 eggs. That's amazing. 3 euploids is slightly low euploidy rate. Euploidy rate, statistically would be around 60%. This is only 33%, but still amazing cycle. I think you can be very happy.
All right. Thank you so much, Fran, for your question and your help with that as well, Dr. Pack. And let's have a look. Liz has a question with embryo donation. Do you know the age of the woman when the embryo was created?
Yes, the embryo can. Embryo donation is there's the same rules than egg donation and sperm donation. The rule is that she, the donor lady, has to be under 35, and the donor has to be under 50. This is by law, regardless whether the embryo is already generated or whether we are generating it for the patients. That doesn't matter. So age of the woman is even one of the data that the patient will receive once she's pregnant and reaches the end of the first trimester. This is when we reveal the age, because it's important for the gynecologist to know the age, because when they want to do the first trimester screening for Down syndrome, age is one of the parameters that enters into the equation. So it's very important to tell that it's egg donation and to tell the age of the donor, of the lady.
Okay, thank you again for that.
I don't think whether when the embryo was created. Okay, this I didn't answer that detail. The embryo, it doesn't matter when the embryo was created, because the embryo is frozen in liquid nitrogen. So the time of freezing does not affect the quality of the embryo negatively. So it doesn't matter. And it's not something that we reveal as I told you, the only data we reveal about the parents of the embryo is the maternal age and the blood group also. Maternal age and blood group of both.
Okay, thank you for the clarification. Okay, let's have a look. Could blastocysts that are euploids that have implantation or develop issues due to sperm DNA fragmentation, or does PGT testing reduce the likelihood of this being an issue?
Okay, when an embryo is euploid, it's supposed to carry 46 chromosomes in the cells. So a priori, it has the best possible success implantation and live birth rates. DNA fragmentation of, I think this person is referring to DNA fragmentation rate of the sperm. This is where we, this is when we speak about DNA fragmentation. So this is something that might also have a negative impact on the euploidy rate, so on the chances that the embryo is euploid at the end. But once we have the result from the PGTA came back and saying that it's euploid, it doesn't matter whether the sperm was fragmented or not. It doesn't matter anymore. This will be a very good embryo. Euploid embryos are the best embryos that we can get. Lower abortion rates, higher, slightly. This is not spectacular. Higher implantation and live birth rates are increased, but not spectacularly. It also strongly depends upon maternal age. But what is clear that is reduced is the chance to have a miscarriage.
Okay, thank you. The same patient would like to also ask about that. It appears to become more and more common to culture embryos to day 7, especially for couples who produced fewer embryos. What is your opinion on culturing embryos to day 7?
Yeah, I've heard that. I've heard this is something that strongly depends upon the culture of and the composition of the culture that is used in that lab. There are cultures that decrease the velocity of the development of the embryo. So an embryo, in order to reach the blastocyst stage, it might take 7 days instead of 6 days. I've heard of some day 7 transfer, but in our clinic, the maximum time an embryo will stay in the culture is till day 6. If it's not a good blastocyst on day 6, then it will not be a blastocyst that we are going to freeze. It will not be a good embryo. This is in our clinic and in our lab. So I don't know whether this is kind of a new strategy. I was told, I asked that once to our embryologist, and the answer was that it depends upon the culture. One of these embryologists said that she was working before in Madrid in another clinic, and that it was quite common to have day 7 embryos, which doesn't mean that it's worse. Okay, in our clinic, day 6 is nearly as good as day 5, slightly inferior, but very similar. And day 7, as I told you, no embryo needs 7 days to reach a blastocyst stage in our lab.
That makes sense, of course. Again, thank you for your interesting question, interesting thing to take a look at. Okay, another question, this time from, Clara. Have secondary infertility egg donation resulted in 2 euploid embryos? The first transfer failed. What can I do to improve my chances for the second transfer? Yeah,
when a euploid embryo fails to implant, it doesn't mean that you cannot get pregnant. You don't have to think that. You know, it's just a huge challenge for every embryo, even a euploid embryo. It's a big challenge to implant. We call it challenge, but we don't. What is a challenging thing there? You know, this is where we have to really understand how implantation works and all the different factors and different cell types and cytokines come together and interact between each other to understand that process. Because right now we just start to understand how implantation works. We're still scratching the surface here. And I'm saying this because we have so many euploid embryos that we transfer in so many perfectly prepared linings, and it fails. We have so many women who achieved their first kid with a beautiful blastocyst and it succeeded as a first attempt, because chances are more or less 50-50 that it succeeds. And then they come back for a second kid and we transfer the same embryos into the same lining, same preparation protocol, obviously, and it's failing. We don't know why. We cannot explain. It is chances are more or less, roughly speaking, I would have to know the details of that case, but roughly speaking, it's more or less 50% for each transfer, possibly a bit more if the embryo has a very high quality. The lining has to be well prepared. The time of progesterone is crucial. The thickness should be at least 6 millimeters. The structure of the lining should be fine. There are many things we look at when we transfer an embryo. This is also very important, to have a very close look to the womb. If it's your last embryo, I would probably also do a hysteroscopy. I would do a hysteroscopy to rule out polyps, fibroids, adhesions, micropolyps. Many of these things are impossible to see in a scan. So this is the purpose of a hysteroscopy. And also an endometrial biopsy, where we look at the window of implantation I mentioned before. Okay, is it really 5 days, or is it better 4 days, or is it better 6 days of progesterone? This is what you can find out. You might improve your chances when you do an endometrial biopsy. We can also analyze NK cells, T helper cells. We can rule out chronic endometritis. All these conditions are well known to have a negative impact on implantation. So I think if it's your last embryo, it's very important to do both, the hysteroscopy and also the endometrial biopsy.
All right, I believe that helped. Okay, so thanks a lot for sharing this with us as well. Okay, more questions are right here. Sarah would like to know, so does your clinic offer any technology advances or advice in cases of recurrent miscarriages with own eggs and donor eggs?
Okay, this recurrent miscarriage, the reasons why embryos that have started implantation stop developing the placenta, it's all about placentation. Okay, so why that really happens, rarely we know. Sometimes the uterus has malformations, a septum or 2 cavities, or the lining is atrophic, is not growing very well. There are different conditions where we know that miscarriages are more common. We also know that it's more common in women who have autoimmune diseases, because the immune system can also be a cause of miscarriage. But many times the causes, we consider that miscarriage and non-implantation can have the same causes. And the only way to find out, there are all these causes that we know that can be issues are detected in the 2 tests that I mentioned before, okay, in the endometrial biopsy and the hysteroscopy. Once you've ruled out all that, and you also need to have done a thrombophilia screening. Thrombophilia means that you might be at a higher than normal risk to suffer a thrombosis. And there is a very extensive blood test that has to be done. And all clinics that dedicate themselves to recurrent miscarriage will order this blood test. This is also, sometimes we might find the cause there. But, many things have to be ruled out. This is also, it is a clear indication to do the tests I've mentioned before, endometrial biopsy, hysteroscopy, and in this specific case, also thrombophilia screening.
Okay, thank you, Sarah. Again, I think it was helpful for you. Interesting question from Kay. Can people apply to be part of an upcoming clinical trial?
Well, it's not that we, yes, it's when we are doing a clinical trial, all the patients that are eligible for this trial, we would offer them to participate in that trial. This is clear. But right now I can't give you specific data on when the trial is going to start. I mentioned it before. We are going to do a trial on ovarian regeneration, and also on endometrial regeneration, where we also use PRP. Just by the way, PRP used in the endometrium is very likely to be helpful, because not only me, but all my colleagues, we are doing this since more than 5 years, and we have really good experience. We just have so little time to investigate. This is a problem, too much work, but we will actually do a clinical trial also for endometrial regeneration. And if it's the case of that patient to be certain criteria have to be met in order to be eligible for a trial. So if this is the case, then the answer is yes. People can participate, but they would need to be a patient here at our clinic, and we would need to have started that trial already.
Okay, thank you. Again, that was again helpful. We will have actually a webinar coming up next month, I think, about PRP, also ovarian rejuvenation, but also endometrial rejuvenation. So just stay tuned, okay? And I'm sure you will find it interesting as well. Okay, Fran would like to know, so how do embryos grades relate if all are euploid? Is grade still taken into account when choosing which to transfer? And if not,
yes,
how do you choose?
Yes, we still take quality in account. But what we see that if the embryo is euploid, morphological criteria are secondary. We just don't take them account so much anymore. We just it might still be better if the embryo is a 5AA than if it's a 3BC, for example. Still, quality could be interesting. We always would transfer the best embryo first. This is what we always do, and even if the embryo is euploid, we do that. Mm-hmm. But we have patients where the grading is not so good. Okay, let's say when there's a C, then when you see a C, then the quality is it's not a D. Okay, we wouldn't even freeze a D embryo. But when it's C, it still can give you a baby, and when it's euploid, then you have really good chances. Then you don't have to think that the C is so bad when it's euploid.
Okay, thank you for the clarification for this again as well. Okay, next question from Claire. If the father is much younger than the mother, 27 or 24, 43, does it increase chances of live birth?
Not significantly. No, we have men are. I told before, the sperm quality is maintained till the age of 45. And we don't see any difference in sperms from a 20-year-old than from a 45-year-old. We start to really notice that sperm could be an issue when the man is over 50, 55. Then we start to notice that there is a negative impact. We might get less embryos, we might get lower quality embryos, and we might also have a lower euploidy rate when we do PGT-A. So, but not before the age of 50. There's no significant effect on live birth.
Okay, all right, thank you. Let's have a look. I have low ovarian reserve, secondary to endo, age 35, poor ovarian response, good fertilization rates in 3 cycles. We've created 4 blastocysts in total. Our consultant not keen on PGT-A as we don't make many embryos. Now had 3 failed transfers. So should we request PGT-A?
Okay, PGT-A. This lady is 35. So in young ladies, we do not recommend PGT-A so much, because chances that the embryo is euploid is much higher. And PGT-A also has a drawback. We are not able to analyze the whole embryo. We only take 5 or 6 cells out of it, and we never ever would touch the cells, which is the embryo itself, called inner cell mass. We never did perform the biopsy there, but we always perform the biopsy in the opposite pole, and these cells are called trophectoderm. So the thing is that if the result from the PGT-A comes back that it's aneuploid, which means that it's a bad embryo and it will be discarded, it will be destroyed basically, because it's not allowed to transfer it when it's aneuploid, you might have had a mosaic embryo that had normal cells in the inner cell mass. So this is kind of a problem when the egg quality is supposed to be relatively good. At the age of 35, it's supposed to be very good. PGTA, we also don't use PGTA so much in donors for the same reason, because also statistically, we don't see a big difference between doing PGTA and not doing it when the eggs come from donor ladies, from young ladies under 35, as this lady who's asking. So the answer is that I agree with my colleague who recommended to not do a PGTA. You would have lost probably out of 4, you might have lost 2 embryos that could have been mosaics. And mosaic embryos can give birth, you can give birth to a healthy baby without mosaicism. It's a bit long to explain what mosaicism means. Mosaicism is, roughly speaking, that the embryo carries both good and bad cells. And it's like a mosaic. Imagine a mosaic with red and green stones. So depending upon where you catch the stones, you might get only reds or only greens. And then you didn't diagnose it that it was a mosaic. If you catch only green cells, okay, we are going to transfer the embryo. It was a mosaic and it can still give you a healthy baby. Slightly higher abortion rate. That's what it means when it's a mosaic. But if you catch only red stones, then you're going to throw away the embryo. And this is why PGTA is not more efficient in young ladies.
Okay.
So
of course.
I think I wouldn't transfer I wouldn't analyze the last embryo for PGTA. You might potentially lose an embryo and lose your last chance. Yeah.
Okay.
If you were over 38, I would say yes, do it. But when you're 35, don't do it. There's a big difference.
Okay. Good. I think that was helpful again, and I hope that it was reassuring as well for you. And let's have a look. Lisa has a question here. So thank you for the presentation. I have had 7 donor egg blastocysts transfer within 6 transfers with no sign of any implantation at all. None of the embryos have been tested. I have not had ERA test at my clinic. Do not believe is this too much due to them being donor embryos. Other than these tests and immunology tests, which I have had, are there any further investigations that I could do next?
Okay. I mentioned before that for us, the ERA test is one of the first tests we do, the endometrial biopsy, and we also analyze immunology. We rule out the presence of plasma cells to rule out chronic endometritis. So I think that a biopsy is actually, together with the hysteroscopy, both exams are pretty important when so many embryos have failed to implant. But we do have a lot of patients where all this has been done and still it's failing. Okay, so I admit that even with these tests, frequently we are not able to find the key to success. So there is one thing that we usually reserve for these cases, and this is the endometrial regeneration. We have had some spectacular cases where it was failing, not once, but multiple times, and where regeneration was an incredible success. You know, it's not always, obviously, it's not miraculous. Otherwise, we would do it even before the first transfer. But we kind of reserve it for these cases where many embryos have failed to implant. So regeneration means infiltration of PRP with a hysteroscopy. So first we have to do a hysteroscopy, and later in the cycle we introduce the PRPs with a transfer catheter. So kind of a lavage of the cavity with PRPs. We do that 2 or 3 times more, and then we transfer. And this is one of the trials that we are going to do very soon to finally prove that it's really efficient. But me and all my colleagues, we are, from experience, we think that it's helpful.
All right. We will be slowly finishing, okay? There are a few questions more I think we can still answer. Dr. Park, okay? So let me just go to this one. So how can one assist on follicle and what impact might it have on the IVF cycle?
Well, if there's a bigger cyst, it basically it occupies space. So other follicles that want to grow might not be able to do that. But I don't think that it normally is only in one ovary. So the cyst can be punctured. Sometimes we puncture it, and sometimes we just leave it. It depends upon the number of follicles. If we find a reasonable number of follicles, we might just start a stimulation despite the presence of the cyst. So we're not giving it such a high importance. But all this, what I'm saying strongly depends upon how big the cyst is, where it's located. Is it a follicular cyst? So it's very difficult to give a precise answer to that question without having seen the cyst. Yeah.
Okay, thank you. Is chemical pregnancy with a euploid embryo a good sign that a future ongoing pregnancy is possible?
Yes, especially in a woman who has never been pregnant. This is like a big step in the treatment. Seeing that a woman who has never been pregnant suddenly demonstrates that she is actually able to get pregnant, and this is very important. So the answer is yes. This would give me confidence. It's still, chances that it might happen in the future. You never know. But with euploid embryos, if you have a strong embryo, this is what at the end will make it happen or not. If you don't have good embryos, then there's no chance. Euploid embryos are the best of the best. There's nothing better than a euploid embryo.
Of course. Okay, Claire, one more question. Being 43, I've been advised to not perform PGTA if we can get a blastocyst stage embryo because it could damage the only viable one. Anything can I add?
This is what I said before. You might discard an embryo that potentially might have given you a baby, but there is a big but. What if it's a trisomy 21 or a trisomy 18? You will not detect that till the end of the first trimester. So this is the reason why I usually recommend the biopsy and doing the PGTA, even if we have only one embryo. In all my women over 38, I usually recommend it. If when she's 42 or 43, I definitely would recommend to do the PGTA.
All right. Again, thank you.
Age related, yeah.
Okay. 2 questions, so I think we can take care of those as well. I have Hashimoto. I will be doing my first donor egg transfer this year. I'm worried about implantation failure. My lining has been good on all my scans, but I'm worried about the autoimmune issues. What things you can suggest I do in order to prepare my body for this transfer to make my lining receptive?
Okay, Hashimoto is very, very common, and it's not by chance that it's so common. There is no good treatment to avoid or to mitigate the negative impact that Hashimoto and autoimmune diseases in general have on implantation failure. One approach is measuring the antibodies and the levels of the antibodies, but there's no evidence that reducing the antibody levels could help in any way. There are different treatments that you can use. I recommend to all my patients with autoimmune problems to do the biopsy even before the first transfer, because we are more likely to detect alterations in the natural killer cells and the T helper cells. And this medication that we use to treat these alterations might possibly also help to reduce the impact of Hashimoto. But still, there's no really good treatment we just have to accept. I tell all my patients with Hashimoto that you might need more transfers than without. So normally a woman without autoimmune diseases with a normal uterus, when we do egg donation, for example, I think with 2 or 3 transfers, it should happen. Okay, 2 or 3. This is what between 1 and 3 transfers. This is what my couples need to have a baby when everything is good. Now, when the woman has Hashimoto, I usually recommend her to go for our 5 blastocysts attempts treatment, where we guarantee that the transfer of up to 5 blastocysts, because she might need more tries. But it's not that it's impossible. We also achieve babies in women with Hashimoto. Just the way might be a little bit longer.
Okay, again, thank you so much indeed. I missed one of the questions, so please let me put that here. So can high Th1 and Th2 cytokine levels and NK activity in the blood reduce the chances of successful implantation and achieving ongoing pregnancy?
Well, this is something we did years ago. We still determined NKs and Th1, Th2 in blood. We don't do that anymore because there's basically no relation between the levels in blood and the levels in the uterus. And it's much more reliable. The NK cells, for example, NK activity in the uterus has a much stronger relation with implantation failure. So we usually don't determine the levels in blood. We do a biopsy and we look for all these cell types, Th1, Th2, also Th17, also T regulators, B cells, NK activity, NK cells, total NK cells, the activated part of those, cytokine levels. All this is determined in an endometrial biopsy, which is much more reliable because this is where the embryo will certainly implant and come in touch with these cells. That's the example of the NK cells, for example. Natural killer cells have that name because in the blood they kill virus. So even the function of these cells in the blood doesn't have anything to do with implantation. So there is no point in determining NKs in the blood anymore. We've stopped doing that a long time ago.
All right. Again, thank you so much indeed. Yeah, thanks from M as well, as you can see, very clear. Okay, Shireen would like to know if I want to try with my own eggs but have premature ovarian failure, FSH over 100, AMH 0.5, AFC1, no cycle without HRT, what would you try, a particular stimulation protocol or really nothing age 37?
At first sight, I would say age 37. Okay, age is still might give you some hope, but the egg reserve is close to 0.5. I guess that the unit is in UK they usually use picomole per liter. So 0.5 picomole per liter. This is basically egg reserve is gone. Even with regeneration, ovarian regeneration with PRPs, even in this treatment would probably not be helpful in this case. At first sight, I would say that this is a very, very complicated case. I don't know whether I would be very clear probably in the first visit and say that we have to speak about egg donation. But obviously, I would never say that without having seen her first, without having seen all the analysis, without looking very thoroughly to her eggs, make sure that there are actually no follicles anymore. But if I see that there's only one follicle, there's no chance. No, I would tell her to not even try. This is my opinion.
All right. Thank you for sharing that. And remember that if you wish to get some more details, obviously, please just get in touch with the team at IVF Alicante so that they can properly see your case. Yes, see all the details as well and the history. All right. As I've mentioned, we'll be finishing. I think that will be our final question. But of course, if we do not answer some of those tonight, don't worry, we'll be definitely able to forward those. And the question is, so is celiac disease an autoimmune disorder and does it impact outcomes of egg donation?
It can. There is some evidence that celiac disease might be also having a negative impact. We also determine the antibodies for celiac disease. It is possible, yes.
Okay, thank you again. Just let me know, Dr. Pak, there are some questions, short ones from Ira, if we can maybe have a look at those. And this will be our final question for tonight, for sure. Okay, so let's have a look. So does the oocyte qualities directly related to the woman's age first?
Yes, strongly, strongly. With high ovarian size, is there a test to stimulate a good quality oocyte? Well, this is a natural selection. The best eggs are surrounded by follicles that grow better. So let's say that the follicles that do grow also have higher chances to contain a good ovocyte. So this is something that nature does for us, select good ovocytes. And this is why we also try to use low doses of, we try to not make all the follicles grow. And that way we select better eggs. We achieve higher egg quality when we use lower doses of hormones. But there's no direct way to find out. Is age the limiting factor? What are the chances of getting pregnant with her own ovocytes? I don't understand that question. Age is a limiting factor. I mentioned before, 45 is, we are speaking about doing this with own eggs.
Right.
Egg donation, there is the only age limit in egg donation is 50. Why 50? Because we consider that there's a considerable obstetric risk to suffer complications during pregnancy. These complications are strongly related also with age. So 50 is the maximum age that we do egg donation. With stimulation with own eggs, 45, 46, sometimes 47, but usually not older. Today I had a 50-year-old requesting treatment with own eggs. We reject. We don't want to treat patients when we don't believe in the treatment. This is,
of course.
It's like this. We have to believe. We have to have a tiny belief at least.
Of course, that makes sense. Okay. And two other, is there a test to determine the quality of the oocytes?
Quality, the quality is seen during the cycle. Once we have taken the eggs, the percentage that is fertilized, the percentage of eggs that reach blastocysts, when we do PGTA, the percentage of euploid embryos, these are the tests that really tell us the quality of the eggs. But there's no way how we can find out before. No. We can imagine how the egg is going to be, but this is, again, statistics, age. Age is strongly related with egg quality. So we have an idea of how the eggs will be.
And the final one.
Is there a test to determine in which cycle a good quality oocyte will ovulate? Well, I'm not sure whether I understood this question. When we do IVF, we have to avoid ovulation. That's why we use agonists and antagonists to avoid the LH peak and make ovulate, because we want to determine the LH peak. And then 36 hours later, we are taking the eggs out shortly before the patient would ovulate. So this is how IVF is done. You know, we let the follicles grow. There's a moment when there's a risk to ovulate. We stop the patient from doing that with usually with antagonists. That's what we use. And then as soon as the eggs have reached a certain size, they're supposed to be mature. Then we inject the trigger injection, and 36 hours later, egg retrieval. That's how it works. I don't know whether I'm answering the question, but
sure. I think that should be helpful for you. But of course, remember that if you wish to get some more details, you can get in touch with the team at IVF Life Alicante. As I mentioned, this was our final questions, those final questions. So thanks everyone for your questions. Dr. Pack, as you can see, there are plenty of comments, very helpful information. And thank you for your response to my question. Thank you for this presentation. Very useful.
You're welcome.
I couldn't agree more. So thank you indeed for
I'm happy to
for
see
your time.
that I've so many
Definitely
really excellently listeners. So yeah,
we are
great.
Definitely happy
this was
that you
a lot
were
of
able
information
to
today.
join
We've
us.
spoken about everything. I
Yes,
don't know, but I also
more or
think
less
that
true.
many of the people who are listening to me are already kind of experienced and probably understand major part of what I was saying, because people
Definitely
study a
so.
lot and read a lot.
And we are also right here just to educate, help as much as we possibly can. So thank you everyone for your time as well and for your questions. I do hope and believe that it was definitely useful for you. And remember that we will be back with some more webinars. Actually, there is a one webinar tomorrow, so I hope you will be able to join us. We will focus on single motherhood, and the doctor, Dr. Ruth Sanchez, will be with us. So I hope you will be able to join us at 7 p.m. UK time. So different time, but tomorrow we will be back. So if you have more questions, you can join us tomorrow. Dr. Pak, it was great to have you. So thanks a lot. Of course, this has been recorded. So if anyone missed any parts, of course, you will be able to rewatch this. Dr. Pak, I know that we probably will have some more webinars coming up soon with you as well. So I'm looking forward to it already. Thank you again. Enjoy your evening and see you soon. Okay?
Yeah. Thanks to everybody.
Thank you so
and
much.
See you in some other webinar or here at Alicante.
Thank you so much indeed.
Good
Take
evening.
care. Bye.
Bye-bye.